Welcome to Health Professional Radio. I'm your host, Neil Howard. Thank you so much for joining us again. I'm going to be speaking with Dr. Lauren Hunt this morning. She's joining us here from the University of California, San Francisco to talk about some new data that was presented at AGS 2021 that raises a few concerns about hospice care for patients with and without dementia. Welcome to Health Professional Radio, Dr. Lauren Hunt.
Hey there. Thanks so much for having me.
I'm hoping that you'll give our listeners a bit of your professional background and talk briefly about your role there at the University of California, San Francisco.
Sure. So I am an assistant professor in the School of Nursing at UCSF. I'm also an Atlantic Senior Fellow for Equity in Brain Health at the Global Brain Health Institute. And my role is mostly I'm involved in research. I research hospice and end-of-life care for older adults, particularly those with dementia. And I have a real interest in looking at policies around hospice and end-of-life and the role of Medicare policies and regulations in this area.
Patients with dementia, patients without dementia, I mean, you're going to get older and, you know, as you said, we're talking about end-of-life care. When it comes to patients with dementia, I understand that they're more likely to be disenrolled from that hospice care before their death.
Mm-hmm. That's exactly right. So it's really interesting, actually, because when people think about hospice, they often think about cancer, right? But the reality is that now, actually, almost half of people enrolled in hospice have a diagnosis of dementia. And this has been a big change over the last 20 years. And something that I witnessed in my clinical practice as a hospice nurse, just taking care of so many patients in hospice with dementia. The hospice model through the Medicare hospice benefit is really still designed around the needs of people with cancer, who tend to have a more certain prognosis, like it's more certain how many months they will have left to live. They also have very specific needs around pain and symptom management. For people with dementia, it's really, really hard to predict when somebody with dementia will die, even when they're really ill. And also their needs are more around, definitely pain and symptoms are still an issue, but they have a lot more needs for assistance with bathing and dressing and caregiver support. Mm-hmm. And so the hospice model is still really designed around the needs of people with cancer. So in order to be eligible for hospice, you have to have a provider say that you have less than 6 months to live. And so for people with dementia, that's really difficult to say. And so what happens a lot for people with dementia is that they're not looking so great. They go into hospice, and then they start doing a little better. Not really not like they're cured, mm-hmm. but they kind of stabilize. And then they're no longer eligible for hospice once their condition has stabilized. And so then what happens is that they get disenrolled from hospice. And people sometimes call this graduating, but I like to say it's a lot more like getting expelled, because it really leaves, hospice provides all of these comprehensive, holistic services in the home, in the nursing home, wherever the patient is at. And then all of those services go away. And there's really no other similar service available right now that provides the same level of comprehensive support that hospice does. And for that reason, patients and families they're left scrambling at a time of life when they really just need the most support possible. So previous research has shown that people with dementia are about 2 to 4 times more likely to experience disenrollment than people with cancer, for example.
The patient looks pretty bad. They go into hospice, they qualify, and then their condition improves. Are we talking about an improvement overall? Are we talking about cognitive function continues? Are we talking about a bed sore clears up? Are there specific conditions that need to be better in order to be disqualified or, as you say, expelled?
Right. So if you have advanced dementia, if you qualify for hospice with advanced dementia, at that point you can't eat, you can't feed yourself, you probably can't really talk very much, and you can't get out of bed. So it's not like a person may still be in that state, but they may be losing weight. And yeah, exactly. They may have had a pressure ulcer that clears up. Probably not so likely that their cognition improves. Mm-hmm. They're kind of just doing okay, and they're not really declining very fast.
As someone who deals with this exclusively, and we're going to talk a little bit about this data that raises these concerns, it mm-hmm. almost seems as though, for lack of a better term, the system is looking for any improvement to disqualify you. Are we replacing that disqualified patient with a qualified cancer patient or another qualified dementia patient? Or are we just looking to latch on to anything because in a dementia situation such as that, an improvement really isn't?
Yeah. Well, it's just really interesting because Medicare, so the other thing that's been happening over the past 20 years is that there's been huge skyrocketing costs in hospice. And a lot of this cost is driven by the increase of people with dementia into hospice because they tend to have they tend to have long lengths of stay that, because it's so difficult to determine their prognosis, that then end in this disenrollment. And this is also, it's tied to really interesting changes in the hospice marketplace, where the hospice marketplace used to be primarily nonprofit hospices and is now 70% for-profit hospices. Private equity is entering the hospice marketplace. It's a very interesting space going on. And Medicare is very, very worried about rising hospice costs. So they are very concerned about people who may not be meeting the hospice eligibility criteria staying enrolled in hospice. So there's sort of kind of a complex array of factors going on here. They're worried that hospices might be keeping patients on too long who aren't eligible, or perhaps enrolling patients in the first place who are marginally eligible for hospice, really just to try to increase those profit margins. So there's interesting things going on in this space around these issues.
How many of these issues that you've briefly touched on here were talked about or revealed in risk factors for disenrollment from hospice in persons with dementia, a National Cohort Study? I understand that data was presented at the 2021 American Geriatrics Society General Meeting.
Mm-hmm. So we presented an abstract at AGS, and we're currently working on finalizing the manuscript, hopefully getting it submitted this summer. We saw some of these concerning, or maybe I'll just say a little bit. We have this, we looked at we have a data set of people with dementia who are enrolled in hospice, all people with dementia between 2012 and 2017. And we've been able to link up this data with their Medicare data, with their information about the hospice providers and the region where they live, and measures around the hospice quality and the neighborhood characteristics. So it's really been a fun and exciting project. And what we're seeing is some of these concerning hospice characteristics, hospice size, and how long the hospice has been in operation. So these were factors that were associated with higher rates of disenrollment. So as you see this hospice market changing, which is a lot of hospices entering the market, small, newer hospices, then those factors were associated with higher rates of disenrollment. We are also seeing a lot of variability, just a lot of from one hospice to another. So the same person who, if you had a hypothetical person who could enroll in two different hospices, the chances of them being disenrolled in hospice B versus hospice A is 50%. So they'd be 50% more likely to get disenrolled from hospice from one hospice to another. So there's a lot of variability there. And there's a little bit less variability around regional geographical area. And then we're just seeing some other concerning characteristics, patient characteristics. Racial and ethnic minority groups are more likely to get disenrolled. People living at home, receiving hospice at home versus in the nursing home, who even need the hospice services more than somebody who's in assisted living or nursing home. So just some concerning findings.
Where can our listeners go online and get more information about hospice care, about hospice patients with dementia and without, and about the study that we've been discussing?
Great. You can go to www.massgeneral.org at AGS 2021.
Well, Dr. Hunt, I appreciate you joining us here on Health Professional Radio. Thank you so much.
Thank you so much. That was great. Enjoyed it.
You've been listening to Health Professional Radio. I'm your host, Neil Howard, in conversation with Dr. Lauren Hunt. Audio copies of this program are available at hpr.fm and healthprofessionalradio.com.au. You can also subscribe to the podcast on iTunes, listen in, download at SoundCloud, and be sure and subscribe to our YouTube channel at youtube.com/Health Professional Radio.